Good afternoon, everyone. A very warm welcome to each one of you. And in the literal sense, a warm afternoon as well. This is our second webinar of the Oncology Insights webinar series. And today, the focus is on pediatric oncology and pediatric hematology. Our webinar focuses on healthcare professionals, but also on caregivers for them to strengthen their understanding and to take right informed decision. Our first webinar was a focus on cancer basics, and we had 198 registrants and 198 people who also took part in the quiz. For that, first, I would announce the winners for the first webinar. And interestingly, the two people on the first position are from the same institute. The first prize goes to Dr. Raksha. She is currently, she has finished her MBBS from ESI Hospital, but currently preparing for NEET exam. And Dr. Shruti SS is a consultant gynae oncologist at ESI Bangalore. Congratulations to both of you. We'll be sharing the award money, the prize money to you by UPI. We'll try to contact you on the phone and we'll be sharing the first prize money of 12,000, but 6,000 each is what we'll do here. The second prize goes to Dr. Aziza Fatima. She has passed her MBBS from Government Unani Medical College and Hospital from Bangalore and currently working in Citizen Hospital. A warm, really, it's very nice to see nice participation, and congratulations to Dr. Raksha, Dr. Shruti, and Dr. Aziza. With this, we start our pediatric oncology and hematology session. And pediatric oncology and hematology is a very unique specialty in which we have to focus on high threshold of doubt. We have to, there are no guidelines of screening, and therefore we have to make sure that we understand what are the subtle signs and symptoms a child could present and have suspicion of cancer or blood disorder. Quite a few blood testings are done at baseline when the baby is born to see whether they have sickle or they have thalassemia. But wherever it is not done, especially in high prevalence areas, they should be tested so that at least we are prepared of what the future is ahead. When we look at the US dynamics, the most common cause of pediatric death is cancer. And this is a very sad number. Across the globe, almost 400,000 kids are diagnosed with cancer each year. Looking at the Indian dynamics, almost 70,000 children are diagnosed with cancer each year, which is an extremely large number. And it is the ninth commonest cause of death in kids less than 14 years of age in India. It may be higher up when we consider less than 19 years of age. Also, the sad fact is that in our kind of countries, lower and medium socioeconomic countries, the death rate is almost double that of high economic country, higher income group countries. So where the results are almost 80% 5-year survival in countries like US and in Europe, in countries like Asian countries and African countries, the results are only 35 to 40%. And this is what we have to find out, and this is what we intend to improve when we treat pediatric cancers. When we look at Indian burden, only 5% of total cancers are pediatric cancers, but they are curable subset with very good tolerance to treatment and very good results if treated on time. So when we look at Globocan data of 2022, this was the last data of India which has been published. It says that leukemias is the most common cause of pediatric cancers. Leukemias with a focus on acute leukemia, and acute lymphoblastic leukemia is the most common cancer. The second commonest cancer is CNS tumors. Brain tumors is the second most common cause of pediatric cancers in our country. And then the third is lymphomas, which could be non-Hodgkin's lymphoma or Hodgkin's. And then, of course, neuroblastoma, nephroblastoma, and other solid cancers. Next slide, please, Meera. When we focus on pediatric cancers, as I said, leukemias, sarcomas, and brain tumors, unlike adults, when we talk about breast, lung, and colorectal cancer, when we talk about adult cancers, the most common etiology is lifestyle. So cancer is the lifestyle disease when we talk about adults, and it commonly happens in aging population. Whereas pediatric cancers, it is primarily genetic mutations, which could happen spontaneously in a kid. It could happen in less than 1 year, it could happen in less than 10 years, and of course, as old as less than 18 years of age. Mutations could be a single point mutation, or it could be few more than one mutation. Pediatric cancers are very responsive to chemotherapy. The focus of such cancers is cure and long time quality of life. The survival rate is more than 80%, 5-year survival. Pediatric subset tolerate treatment much better than adult subset, but the drawback of treatment is long-term side effects, which could be hormone issues, which could be growth and development issues, and sometimes infertility. There are less number of cases, and therefore less research and less trials focus around pediatric cancer. Next slide, please. So the focus today and our talk today is based on awareness, accurate and early diagnosis, and right access to healthcare. Please remember that cost may not be a major concern in pediatric cases because there are a lot of funding platforms, a lot of NGO activities which actually support pediatric tumors and pediatric cancer treatment. So please go to a doctor if you have any subtle sign and symptoms which is unexplained. Even conditions like long-standing anemia, long-standing blood disorders like thrombocytopenia, if you see any mass in any part of the body, if you have any swelling in the neck or underarms, if the baby has any blood from any site in cough or in blood, urine or in stools, or if there is any chronic symptom like weight loss, chest pain, chronic cough, please bring to medical attention. With this will be the first presentation by Dr. Shweta. She is radiation oncologist in Fortis Group of Hospitals, and she'll be talking about red flag signs. Over to you, Shweta.
Hello, Dr. Shweta, are you there?
Yeah.
Just a
Can you
second.
hear me? Yes.
Just a second. Just click on the slide once, ma'am. Yes, you can move it, ma'am.
A warm afternoon, everyone. I'm going to present about the red flag signs in childhood cancer. As you know, childhood cancer is sometimes people think that it's nothing but earlier form of adult, how to manage. It's the same like earlier form of adult, but that is not the case. And picking up of a childhood malignancy is difficult because it is insidious in onset. It doesn't have a particular screening of techniques also to identify very easily, and insidious in onset. So why this early diagnosis? Mainly clinical examination to rule out these red signs which can be picked up from the child is very important, is because most of the presentation which we see in a clinic is a late presentation, missed out presentation, where the patient present at a later stage of disease. So if we are able to pick up these signs early, it will give a chance for the child to survive and a chance for a cure. And in oncology setup, it's for us. We usually see oncology cases. So our first diagnosis will be any patients, any abnormalities. First thing we'll rule out is malignancies. But that is not a practice in a general practitioners and pediatricians. So it is prudent to have a clinical a watch over the clinical signs and symptoms which the child present, and also with the parents complain, so that pediatric cancer can be detected at an early stage. So in pediatric cancer, there are two groups of malignancies which should be held detailed by the next presenters: hemato-oncology malignancies and solid malignancies. Coming to the risk factors of pediatric malignancies, mainly ionizing radiation. Ionizing radiation may be exposure when the mom is pregnant during the second and third trimester, or when the child is exposed to radiation in early stage of life, or in treatment of any other conditions where the patient has been exposed to X-ray therapies, radiotherapy for management of the disease, and certain chemicals and drugs which has been proved, like the diethylstilbestrol, which has proved which was used as an antiemetic medications, has proven to cause vaginal cancers in children, in female childs, and pesticides exposure, benzene exposure, or tobacco, alcohol, diuretic. These are some proven noted chemicals and drugs which have shown malignancies like leukemias and other solid malignancies in children's. And coming to the biological factors, mainly infective agents, exposure to EBV Epstein-Barr virus, which is prone to cause malignancies like lymphomas and nasopharyngeal carcinomas, and immunocompromised state like human immunodeficiency virus, which may cause again leukemias, lymphomas, and certain malignancies. HCV is prone to have hepatocellular carcinomas. So early exposure to these infective agents are also as risk factors of childhood malignancies. And more common genetic and familial factors. Here, there are some syndromes associated with increased risk of childhood cancers, mainly Down syndrome, which is associated with acute, where the child, more than 10% of the child have a chance of developing acute lymphoblastic leukemias. And retinoblastoma gene disorder, which can cause retinoblastoma, RB gene disorder, which can cause retinoblastomas and other pinealoblastomas. And certain diseases like Lee-Fraumeni syndromes, Danish-Dash syndromes, and VAGR syndromes, which are prone to have multiple malignancies in children. So, and another risk factor is also second primaries. The younger the child has been exposed to, has developed cancers, and certain treatments like exposure to radiation, high dose radiations, and chemotherapies like alkylating agents and topoisomerase inhibitors has shown that the chance of developing a second malignancies is high. So they always will be on follow-up to rule out the chance of second malignancies also. Coming about to how to assess the possibilities of cancer. So first, only for the first and foremost is pick up any danger signs which either the child shows or the mom complains. It can be anything. It can like a common constitutional symptoms like fever, diarrhea, vomiting, myalgia, pain, or baby is irritable state. So these are the symptoms which occurred, history of the child, developmental status, everything. Then feel for certain danger signs, which I am going to be discussing in the later slides. So first and foremost, constitutional symptoms like fever. If the fever is prolonged for more than 7 days with no identifiable cause of viral infections or any infective or any other inflammatory changes, then it is good to look out for there is any other differential diagnosis for fever of unknown origin. Next, if the same fever is being associated with the child looking paler, fatigue, malaise, reduced activity, anorexia, and if the child has lost weight of more than 10% of the body weight in 6 months, if he or she presents with the B symptoms like drenching night sweats, fever, and significant weight loss, along with lymphadenitis plus or minus, then it is better to rule out the possibility of Hodgkin's lymphoma. And any hemorrhagic diastasis like petechiae, if you see, examine the skin, there is petechiae, ecchymosis, recurrent epistasis, bleeding from anywhere, bleeding gum, perirectal bleeding, vaginal bleeding, then it can be pertaining to any growth or disorders, growth or in the particular site, or it can be any malignant hematological disorders which is causing infiltration of the marrow and suppressing the cells, which leading to thrombocytopenia. Look out for hepatomegaly, splenomegaly, and lymphadenopathy. The leukemia patients, 2/3 of the patients present with the triad of anemia, purpura, and fever. So this is why having a prudent watch of constitutional symptom is important. Next comes to lymphadenopathy. Lymphadenopathy is very common in children. The primary the differential diagnosis would be infections, any oropharyngeal infections, any upper respiratory tract infections. But it is always wise to look out if the lymphadenopathy is progressing over more than 4 weeks of period. If the size is increasing in size and is more than 2 centimeter, usually it present unilaterally, but not always. And there is no oropharyngeal or cutaneous infections. If the lump is have an addition in deeper layers, and whatever constitutional symptoms which have been discussed, if the child presented with constitutional symptoms and you have not found any signs of infections, then it is better to rule out evaluate this lymphadenopathy with further investigations. Next comes neurological symptoms. Neurological symptoms, mainly if the child is less than 2 years, if child will have an unexplained irritability, lethargy, there will be developmental delay. The child will present with increased head circumference as shown in the picture, which is a signs of increased intracranial pressures due to the brain tumors. Next sign will be headache. In little older children, they will have present with severe early morning headache, and child awakes with pain, headache, or associated with vomiting, papilledema, blurring of visions, which are the signs of increased intracranial pressure. Or if they can present with any neurological deficit, either cranial nerve palsies, motor and sensory deficits, ataxia, incoordination, if there is involvement in the posterior fossa of the brain. And you also have to look out for seizures, which is common only in less than 10% of the CNS tumors. Mainly focal seizures is common, and unexplained deterioration in school performance or personality changes when the child is throwing tantrum so much, or he or she is suddenly quiet without talking to anyone. It is better to look out for the signs. Gastrointestinal symptoms, any abdominal mass or any mass else anywhere in child's body, it's always a high degree of suspicion. So always look any mass, you have to evaluate the child. Second, if the patient has sudden onset of constipation, if it is persisting for a long period and not responding to conservative treatment, and if the child, you have to rule out if the child is more than 6 years with intersusception, then it is better to rule out abdominal lymphomas. If the child have continuous diarrhea, which is not controlled, and if he is having intractable watery diarrhea, then one of the cause may be due to vasoactive intestinal peptide secreting neuroblastomas. Then coming on to muscles and bones, if the child usually most of the child presented with a history of trauma followed by notice swelling, which is not decreasing in size, or they will present with severe bone pain. Usually child awakens at night crying out in pain, pointing to his limb, which will be continuous, persistently increasing in frequencies. Or if it is a localized pain where you can see a ill-defined swelling or deformities, which may be a cause of, maybe due to any bone tumors like osteosarcomas. Or if the patient present with generalized fatigue or myalgia, which is, if we have ruled out the benign causes and it is prolonged for a long time, maybe one of the cause for leukemias or hematological discrepancies. If the patient is having joint pain, arthritis, it is other than the inflammatory states, it is better to rule out leukemias and other soft tissue tumors. If there is a disruption of normal gait and reduced motor functions, that child will suddenly develop a limping gait. He'll not be able to put his leg down. Then it is a danger signs. Or if the child complains of not able to carry his bag, he's having back pain, which is not reducing, it is prolonged over a long time. Then it is there's one sign to look out for there is any bone tumors or any compression of the spinal cord because of any other mass. And sudden onset osteoclasis also is one due to any muscle involvement. Here, the first picture shows diffuse bone involvement, which is in the case of osteosarcoma. And the second also appendicular area, little older child, the case of Ewing sarcoma. The CT findings also have mentioned, which can distinguish, simple CT with 2 joints can distinguish what type of tumor it presents. Genitourinary symptoms, hematuria. Usually, hematuria in children is not very, maybe due to infections or hematological discrepancies. But if such common causes has been excluded, then the other differential diagnosis like renal tumors and soft tissue sarcomas should be considered. And if a child having urinary retention or enuresis, then it may be due to spinal or pelvic tumors. Vaginal rhabdomyosarcomas and certain hormone-secreting germ cell tumors will present with vaginal bleeding and mass. And in a child, older child, scrotal mass is very common. So it is better to, if there is a sudden scrotal mass, it is better to rule out any germ cell tumors. And if there is an isolated right-sided varicocele, the pathology should always evaluate whether there is a right kidney is proper, or which may occlude the vessels. Or if the child presents with priapism, it may be due to leukemias. So CVS and RS system, if the child have more non-productive cough for more than 2 to 3 weeks, orthopnea, dyspnea, or any structures of SVC occlusions like facial puffiness, plethora, then you have to rule out any mediastinal mass or pleural effusion, which may be caused to lymphomas and leukemias. And hypertensions, which may be due to Wilms tumor, neuroblastomas, and pheochromocytomas. In ENT, any swelling, chronic otorrhea, and nasal obstructions, epistasis, dysphagia, it may be due to any disease lying in the certain area, like in the nasal area, like which may be due to nasopharyngeal carcinomas. In skin, you always look for pallor, conjunctival pallor, if not at least palmar pallor. Usually, pallor will be noticed when the child is hemoglobin is less than 11 gram per deciliter. Any bruising or petechiae. And one feature of blueberry muffin, which is seen in the first child, subcutaneous bluish nodules, very common in neuroblastoma. If the skin nodules, multiple skin nodules, histiocytosis and leukemia has to be evolved, has to be worked up. And pruritus in case of Hodgkin's lymphoma. Histiocytosis also present with scaly seborrheic eczematous rashes, usually around the scalp and ear canal, sometimes in other parts also, which does not respond to corticosteroids. Coming to ocular signs, usually strabismus, squinting, and diplopia is the first symptoms of tumors of the eye or the brain. In case of retinoblastoma, leukorrhea, which the mother may complain like the child's eye is reflecting in the night, which is called cat's eye. Or in case of neuroblastoma, periorbital ecchymosis, which is called raccoon's eye. And a condition called aniridia, which is absence of secondary iris, which is caused due to, which is associated with Wilms tumor. Endocrine symptoms. Certain endocrine symptoms will be hormone secreting tumors, like diabetes insipidus will be the symptoms of craniopharyngiomas and certain pituitary tumors. Growth arrest in craniopharyngiomas, pituitary tumors, hypothalamic tumors, precocious puberty, and pubertal delay. Coming to paraneoplastic syndrome, these are because of certain tumors, there will be secretion of certain enzymes and hormones, which may have some unexplainable symptoms. So these are the red flag signs of childhood. So all signs which is prolonged for more than 2 weeks should always be evaluated. Whenever child presents into the clinic again and again every week with the same symptoms, it is better to pick out these red flag signs, if not, and refer to a higher center for further management. So remember, we can detect it in time and give a chance for cure. Thank you.
Thank you, Sweta, for your insightful presentation. It is very clear that
Yes.
So thank you, Sweta, for your insightful presentation. It is very clear that you spend a lot of time and research for your presentation. Now we move on to quiz. So kindly click the link for quiz.
You say next.
So next slide, please. So round number 1, first question. So what is the most common pediatric malignancy? Round number 1, first question. What is the most common pediatric malignancy? A. Neuroblastoma. B. Wilms tumor. C. Leukemia. D. Medulloblastoma. Total 30 seconds. 5 seconds more. Question number 2. Which genetic syndrome is most commonly associated with increased risk of leukemia in children? Choice A, Turner syndrome. Choice B, Down syndrome. Third choice, Marfan syndrome. Fourth, Klinefelter syndrome. 15 seconds more. Question number 3. Which of the following tumor markers is commonly elevated in hepatoblastoma? Choice A, alpha beta protein. Choice B, CEA. Choice C, LDH. Choice D, beta HCG. Question number 4. What is trilateral retinoblastoma? First choice, bilateral retinoblastoma with neuroblastoma. Bilateral retinoblastoma with nephroblastoma. C choice is bilateral retinoblastoma with rhabdomyosarcoma. D choice is bilateral retinoblastoma with pineal gland involvement. Question number 5. So when is International Childhood Cancer Day celebrated? Choice A. Choice A, 4th February. Choice A 4th February, choice B 5th February, C 8th May, D 28th May. So next session by Dr. Nishit, case-based discussion on blood disorders in children.
Good afternoon, everybody. So we're just starting with the introduction. In India, the leukemia is the most common cancer among children, accounting for approximately 40 to 50% of the pediatric malignancy. ALL is the predominant subtype, representing about 60 to 85% of all childhood leukemia cases. Estimated annual incidence of leukemia among Indian children from 0 to 14 years is around 11,850 cases. Next slide, please. Sickle cell disease accounts for approximately 14.5% of all global sickle cell disease newborn. Thalassemia, the average carrier frequency of beta thalassemia in India is approximately 3 to 4 percentage. Central India, South India, and Eastern India, you can see the different percentage. In South India, it is ranging from 8.5% to 37.9%. Next slide, please. So let me look at few of the cases and how it will help you to come to a diagnosis. There is a 22-year-old male presented with in emergency with complaints of chest pain, shortness of breath, prior hospitalization history with splenic sequestrum crisis at age 15 was told. Next slide, please. On further evaluation, the pain was sudden in onset, sharp chest pain, worse with deep breaths, shortness of breath progressively worsening, cough with yellowish sputum, fever of 101.3 Fahrenheit was recorded, fatigue, dizziness, mild headache, recent history traveled, mildly dehydrated. Looking at the past CBC parameters, once LDH and indirect bilirubin came elevated, and a chest X-ray showed left lobe infiltrates, and ABG showed a parameter of hypoxia. We also sent for HPLC, and that HPLC report of SS came 80%. So the diagnosis of this patient is sickle cell anemia. Next slide, please. Next slide, please. So how do you manage such a patient? The management is on multiple folds. In first, to give oxygen therapy. Pain should be managed with fentanyl. Up to fentanyl, morphine is generally avoided in such patient because it causes respiratory depression risk. Empirical antibiotic should be started in cases of fever. Antibiotic that covers for streptococcus pneumonia and mycoplasma should be considered. Hyperhydration or increased hydration should be given, but not to give overhydration to prevent pulmonary edema. Blood exchange transfusion if severe, if the hemoglobin is less than 6 gram per deciliter, or has the patient anytime received any exchange transfusion should be considered. Monitoring of complications, ICU admission should take place if the respiratory failure develops. Monitoring for stroke symptoms or worsening anemia should be considered for such patients. They are the few indications when these patients should be taken for a bone marrow transplant. In those indication is several vaso-occlusive complications, more than 3 such episodes per year, stroke or high stroke risk, severe end organ damage like avascular necrosis, hip, bone marrow failure or severe anemia, recurrent pyrism, debilitating leg ulcers. Uh, Next slide, please. So this was the first case in which we discussed sickle cell. It is an emergency presentation, and if treated properly in multifolds, the patient can have a good life. Second case number 2 is a 5-year-old male diagnosed with severe anemia at 1.5 years of age, requires regular blood transfusion, showing signs of growth delay and pallor. Family history of consanguine marriage is present. Next slide, please. Parents report progressive pallor and weakness, reduced appetite and poor weight gain, mild jaundice noted for the past few weeks, increased abdominal swelling, possibly due to enlarged spleen. Last blood transfusion was given 4 weeks ago. Skin looked pallor, mild jaundice is present. Facial features showed frontal bossing, prominent maxilla. Abdomen showed splenomegaly, palpable up to 6 centimeter below the costal margin. Hepatosplenomegaly is also present, 4 centimeter below the costal margin. Next slide, please. We sent for a routine test. Hemoglobin was 6.5. MCV was 68. Retic was 1.5. Ferritin 1000. Total bilirubin indirect again elevated. Peripheral smear showed features of microcytic hypochromic anemia. And electrophoresis showed when we did was HbA2 is mildly elevated, but HbF is significantly elevated. So the diagnosis of this case is thalassemia, transfusion dependent thalassemia major. Next slide, please. Next slide, please. So how do we manage such patients? So the patient should be managed with blood transfusion therapy. Post transfusion, the hemoglobin level should be maintained between 9 to 10. A good chelation therapy is very important because according to Luca Veri's classification of thalassemia to be taken for transplant, if the ferritin is kept below 500, comes into low risk criteria. Folic acid supplement is given to support RBC production. Consider bone marrow transplant. Earlier the age, better is the outcome. Coming to third case, as you can see, a 14-year-old boy, fever for 15 days, cough for 7 days, loss of appetite. On examination, cervical lymphadenopathy was uh, present, sent with cough syrup with antibiotics. A chest X-ray showed that mediastinal widening. Next slide, please. CBC done showed hemoglobin of 9.8. Counts were okay. Platelets were 1.8 lakhs. After 1 week, presented in ER with respiratory distress, and this time the count has suddenly jumped from 2.3 lakhs. Chest X-ray showed a mediastinal mass. Immediately, a flow cytometry was done. A TLL diagnosis was made. So once the diagnosis of TLL is made, we should send for FISH, karyotyping, and NGS to risk stratified and immediately start with any of the protocols, BFM, GMOL, but in those protocols, the steroid is the first line of treatment and that should be given. And it greatly depends whether the treatment is steroid responsive or not responsive. TLL differs from BLN in one aspect that TLL will have high predisposition to affect the sanctuary sites like CNS and testis. Next slide, please. Coming to the fourth case, a 5-year-old boy presented with complaints of fever for 3 months, swelling on the neck for 2 months, history of weight loss of 5 kg in the last 3 months. FNSE showed granulomatous region, was treated for ATT for 1 month. On examination, he had significant lymphadenopathy. Biopsy showed features of Hodgkin lymphoma. Next slide, please. So when you have a case of enlarged lymph node, how do you approach it? So if it is enlarged lymph node, non-suppurative, local cause, cultures and serology, non-local infection, abnormal CBC, abnormal chest X-ray, supraclavicular in nature, rapidly enlarging or fixed weight loss present, we do a bone marrow aspirate. If it's diagnosis, we treat it. If non-diagnosis, we biopsy the lymph node. In cases where there's normal CBC, normal chest X-ray, no supraclavicular lymph nodes, not rapidly injecting, we do serology, skin test. If it comes diagnostic, we treat it. If non-diagnostic, we give a trial of antibiotics, wait for the response. If still no response, then we biopsy it. If it is suppurative in nature, give fluctuant, aspirate for diagnosis, non-fluctuant skin test, chest X-ray, and similarly we treat. If non-diagnostic, then you go for biopsy. Next slide, please. So these are the red flags in cases of cervical lymphadenopathy. A lymphadenopathy of more than 2 centimeter, steady increase in size over 2 to 3 weeks, no improvement or decrease in size after 4 to 6 weeks, supraclavicular lymphadenopathy, hard, fixed, matted, non-tender lymphadenopathy, persistent fever lasting more than 1 week, sign and symptoms of suggestive of malignancy, weight loss, petechia, pallor, night sweats, and hepatosplenomegaly. Signs and symptoms suggestive of autoimmune disease, rash, arthralgia, arthritis, and generalized lymphadenopathy. These features could suggest of Kawasaki disease and abnormal in blood cut and chest X-ray. Next slide, please. So thank you. These are the few cases we have discussed. Actually, Dr. Shweta has divided the case very nicely. So these are the few interesting ones which we could pick up and discuss. Moving on to quiz round number 2. Thank you.
Thank you, Nishit, for your excellent presentation. Next we move on to quiz number 1. So, Philadelphia chromosome is associated with childhood leukemia. Option A, acute lymphoblastic leukemia. Option B, AML. Option C, juvenile myelomonocytic leukemia. Option D, acute promyelocytic leukemia. Question number 2. In tumor lysis syndrome, which electrolyte abnormality is typically not seen? Choice A, hyperkalemia. Choice B, hypocalcemia. Choice C, hyperphosphatemia. Choice D, hypermagnesemia. Question number 3. Which molecular marker is commonly associated with poor prognosis in pediatric ALL? Choice number A, hyperdiploidy. B, TEL and AML translocation. C, MLL rearrangement. D, RUNX1 mutation. Question number 4. Most common cause of mass in anterior mediastinum in children. First choice, rhabdomyosarcoma. Second, duplication of cyst of esophagus. C, lymphoma. D, neuroblastoma. Question number 5. What is the translocation seen in APML? Choice A, 1221. Choice B, 119. Choice C, 1517. Choice D, 922. To our next speaker, Dr. Tanusri, case-based discussion on solid tumors in children.
Am I audible?
Yes, madam. Click on the slide once, ma'am, please.
I'm clicking. Otherwise, you just change the slides. That's okay for me. Very good afternoon to everyone. So, as already discussed by our previous speaker, that leukemia is the most common cancer in pediatric childhood, followed by CNS tumors and other solid tumors. Leukemia has already been discussed by Dr. Nishit. So, I will discuss about CNS tumors and other solid tumors. In other solid tumors, most common in children are the Wilms tumor, retinoblastoma, neuroblastoma. Sarcoma, I will not discuss because we have one session on sarcoma coming on the next webinars. So I will go case number 1, 4-year-old boy with complaints of abdominal distension in left upper quadrant of abdomen for 15 days and hematuria for 2 days. On examination, the child was active and playful. He had only had hypertension and he has a lump present in the right flank of the abdomen. On examination, it was non-tender mass and it is in around 3 to 4 centimeter. So ultrasound abdomen was done, which showed a hypoechoic mass in the inferomedial part of the left kidney. So when a child is coming with an abdominal mass, few histories we have to take, like depending on the age of the child, if the patient is younger age group and coming with a persistent abdominal mass, then we should think of neuroblastoma or hepatoblastoma as the tumor. And if in older children, we should think of lymphoma, Wilms tumor or germ cell tumors. So there may be some associated symptoms with the abdominal distension, which will help us to take our decision what type of tumor it is. There may be associated with pain, constipation, difficulty in passing urine, or other constitutional symptoms like fever for longer duration, associated with bone pain, weight loss, and loss of appetite. So along with abdominal mass, these histories has to be taken. Proper clinical examination should be done head to toe to see for other signs other than a mass, like they may be associated with some syndromes. So we should look out for any cutaneous symptoms like skin changes are there or not, any hepatosplenomegaly, other things are there or not. So when we come to an abdominal mass, so basically most of the abdominal mass in children are benign, like hydronephrosis, ascites, or some gaseous distension, intestinal obstruction, renal vein thrombosis, cystic kidneys. I will not go much in detail with the benign causes of abdominal mass, but in malignant causes, it may present like Wilms tumor. In Wilms tumor, a mass will be felt in the flank, in the right or left flank of that abdomen, and the child will be playful. And in neuroblastoma, there will be a mass in the flank, but the child, along with that associated symptoms like fever may be there, raccoon eye, as already discussed by our previous speakers, will be there. In Burkitt lymphoma, there will be mass around the umbilical region. Along with that, the child will be sick, high-grade fever may be there, constipation or signs of intersusception can be there. And hepatoblastoma, this hepatoblastoma mostly presents in infant age group. So in children, it is very difficult to find out the which quadrants also, because when they are infant, it is not so any mass is there. It should be confirmed with other symptoms, and other like ultrasound should be done. Germ cell tumors, hepatosplenomegaly, and rhabdomyosarcoma are other causes of malignant causes of abdominal mass. So any child coming with an abdominal mass, first of all, radiologically ultrasound should be done. That will give us a lot of idea what type of mass it is. If it is associated with a renal mass, then along with or without a thrombus, then we may think of Wilms tumor or other renal masses. Or if it is a suprarenal mass, then we think of neuroblastoma. If there are some lymph nodes present with or without intersusception, then then we can think of lymphoma. Or in the hepatoblastoma, there will be a SOL in the liver. Or in the pelvic region, if any solid cystic mass is there, then we should think of germ cell tumors. Again, when we send a child with abdominal mass to a radiologist for finding out what is the cause, with that we should give some history. So that the radiologist also come to know what they have to look for. Otherwise, many a times we send a child with a big abdominal mass to a radiologist and we don't get any information properly. Just if we can write, if we are thinking of a Wilms tumor, neuroblastoma, that will guide the radiologist more, and there is less chance that we miss any diagnosis. Along with the radiology, we should do some ancillary blood tests so that we can confirm our diagnosis, like complete blood count. In that, if there is some cytopenia is there, then we can think of leukemia or lymphoma. In case of like tumor lysis syndrome, RFT we have to send to rule out lymphomas. LDH will be increased in lymphomas. Then if we are thinking of hepatoblastoma or germ cell tumors, we have to send certain tumor markers like alpha fetoprotein, beta HCG. So from the blood test and the radiology, we'll have certain idea what type of tumor the child is having. Then we can go ahead with the biopsy. But in certain tumors, the biopsy is not required when it is quite evitable that the child is having that tumor only. Because in the periphery, at times it is not available for children to undergo biopsy. The setting may be poor. So in rural areas, certain like Wilms tumor, any child presenting with 1 to 5 years of age with certain renal mass in the ultrasound, and it is confirmed by CT also, then we can go ahead with the treatment instead of waiting for the biopsy. Or a small infant coming with a very high alpha fetoprotein and the CT is showing a SOL in the liver, we can go ahead with the treatment of hepatoblastoma instead of waiting for biopsy. So these are I have just given a table in which I compared among the most common malignant abdominal mass in children. First, most common is the Wilms tumor. This Wilms tumor is mostly seen in children around 1 to 5 years of age, and they are mostly active child. They will come with no other symptoms, just a swelling in the abdomen, and the incidence is around 5%. And if we do an ultrasound, we will get a upper, mid or lower pole of the kidney. Some mass is there. In CT imaging, the claw sign can be seen. Then comes the neuroblastoma. Neuroblastoma is mostly seen in children less than 18 months. So the more little infants, and it is the most common extracranial tumor in infancy. In neuroblastoma, if they are high risk cases, then the child will be sick. They will be having fever, some bleeding, or some raccoon eyes, along with an abdominal mass. Then we should think of neuroblastoma. And in ultrasound imaging also, we'll get calcification and the mass will be crossing the midline. In Wilms tumor, the mass won't be crossing the midline. Hepatoblastoma is mostly seen in infant age group, 6 months to 3 years of age. It is a rare tumor. Here also the child will be active, playful. And if we suspect hepatoblastoma, tumor markers like AFP can be sent, which will be in most of the cases, it will be increased. Coming to non-Hodgkin's lymphoma, it is mostly seen in little elder childs, like around more than 10 years of age, and they mostly present with abdominal emergency, like they will present with intussusception, and they will. It is one of the most common tumor in children's, and if we see the tumor lysis markers, it will be raised, and in the imaging we will just see that there is intussusception, lymph node involvement is there. And another most common abdominal mass is germ cell tumors. Germ cell tumors, it has bimodal presentation. It is also rare. It is mostly seen in the pelvic mass as a scrotal swelling or swelling in the vagina, or some sacrococcygeal teratoma is there. And in ultrasound, some swelling will be there, and retroperitoneal lymph nodes may be present. And in investigations, tumor markers increase, there will be increased AFP and beta HCG. So management, I am not going much in detail because as we all have discussed till now, that it is a multidisciplinary approach. Whenever a tumor is there, first the pediatrician or physician, whoever is suspecting, instead of confirming the diagnosis, they should send the patient to a place where all the facilities are available for diagnosis. They should not wait for confirmation of the diagnosis. Any suspicion, you refer the patient to a higher center where a facility for oncology treatment of pediatrics children are there. Pediatrics are little different from adult oncology because for all procedures, they will need sedations, proper ICU should be there. So it is a multidisciplinary approach. And again, depending on the type of tumor, we will give chemotherapy, surgery, radiation. Generally, it is avoided in pediatric tumors, but in certain cases, in advanced cases, we do give. And autologous HSCT is done only in rare cases like high-risk cases or relapse cases. We go ahead with autologous HSCT. The main thing is that once we diagnose early, the treatment will be little less and the morbidity will also be less. As we diagnose late, the treatment will be also complex, the morbidity will be also more, and the chances of high toxicity will also be more. So next case, 7 years old, Edin presented to pediatrician with complaints of frequent headache, nausea, vomiting, and difficulty in walking. Her parents also noticed decline in his academic performance over the past few weeks. On CNS examination, he had increased intracranial pressure, including papilledema, ataxia, and some weakness in the left leg. MRI was done, which showed a posterior fossa mass with no spinal metastasis. CSF analysis we did, there was no blast in presence. So since the patient has increased ICP, initially we have done VP shunt to reduce the increased ICP. Along with that, anti-edema measures were also given. Biopsy was done, which was suggestive of medulloblastoma, WHO grade 4. Then the child underwent gross total resection of the tumor, followed by radiation, craniospinal radiation, and chemotherapy. And now the child is doing well. So pediatric brain tumors. So these are the second most common tumor in children. When I talk about brain tumors, we will discuss both brain as well as the spinal cord. So these are around 18 to 8 to 15% of all childhood cancer constitute brain tumor. And at times they may be associated with certain syndromes like Life-Romani, Tarcott syndrome, Corden syndrome. So we have to do head-to-toe examination. And these pediatric brain tumors are more important because this is one of the tumor where the diagnosis is mostly delayed. It will take around 6 months. We have seen the patients are moving around from doctors to doctor. Mostly 6 months to 1 year it takes for the patient to get diagnosis. So it is one of the leading cause of death also. So just few basic about brain tumors. So how do we name it? What is the classification? So basically, if we see the brain tumors, because there are 5 types of brain tumors can happen depending on the type of cells, like intrinsic to brain, which are the glial cells. Glial cells are the supporting cells. They are present in the as well. It's in the supratentorium as well as the infratentorium. In glial cells, there are 3 types of cell. One is astrocytes, oligodendrocytes, and ependymocytes. Depending on that, the naming are also done: astrocytoma, oligodendrogliocytes, and ependymocytes. Neural tissues are mostly the embryonal tissue. Depending on the location of the tumor, they are named. If it is in the posterior fossa, we name it as medulloblastoma. If it is in the lateral ventricles or throughout the brain, then it is named as CNS peanut or ATRT. And choroid plexus are the cells which lines the ventricle. So it will be around the lateral ventricle. The lining is there. So choroid plexus tumors are seen in the lateral ventricles. when certain tumors which are not originated from the CNS but get entrapped into the CNS, those are germ cell tumors or craniopharyngioma. So most common pediatric brain tumors are those astrocytoma, medulloblastoma, and ependymoma. So are all, like, it is a brain tumor. Why are we giving systemic therapy? Like, if we remove the tumor, why are we not just doing that? So these tumors are, as per the WHO, they have graded into low grade and high grade. Low grades are benign. They have less chance of mitosis, and ATP of cells are less. In high grade tumors, which are mostly malignant, they have rapid growth and they spread to other parts like CNS. They can have seeding to the CSF also. For that, they are considered as systemic disease. So along with the removal of the tumor, we have to give some systemic treatment also. So depending on the signs and symptoms, there are 2-3 things we have to think when we think about the signs and symptoms. So it can be divided as per the age as well as the type of tumor, the location of the tumor. And another than that, if their patient has developed any obstructive symptoms. So when an infant has developed some obstructive hydrocephalus-like symptoms, then their head will grow. Their head will be enlarging more. They will have macrocephaly. Along with that, infants cannot say headache, though they will be irritable. Along with that, some vomiting will be there, recurrent vomiting. And there will be delay in the milestones, like the child start, like a 10-month, 12-month child who has started walking, now that child will stop walking and start to crawl. So any regression in the milestone or delay in milestone, then we should think of brain tumors. Then depending on the location of the tumor, if it is in the posterior fossa mass, then the child may have difficult that vision. There will be, the child cannot say loss of vision. They will be trying to balance this by doing abnormal head positions or some behavioral changes, mostly irritability they will have. In little adult child, they will have recurrent headache, mostly in the morning, and recurrent vomiting will be there. So headache is a very vague term. So it's we have to be very conscious while diagnosing, because many people, just child will sometimes do malingering not to go to school. They will have headache. They will say they are having headache. But if persistent headache is there is persistent vomiting, mostly in the morning hours. Along with that, some behavioral changes, or there is some abnormal eye movements, we should more think of brain tumors. Now, management. So management, again, I'm telling you, I will not discuss much about the management. Once we suspect a brain tumor, always at first, before we send the child, we have to stabilize the child. If the patient is having severe headache, vomiting, get an urgent CT, at least, because MRI may not be available everywhere, but CT is mostly available. So if we see there is raised features of raised ICT, like there is bulging of the ventricles are enlarged, then emergency neurosurgeon we should consult, and we should try to go for VP shunt so that we decrease the increased intracranial pressure. Along with that, anti-edema measures should be started, like we'll start dexamethasone, mannitol. After we stabilize the patient, then we will start off what is the type of tumor. We can do biopsy. Biopsy, again, is not done in all the brain tumors, depending on the site. If it is a midline tumor, that the site, there may be increased chances of bleeding and we may injure the vital parts. So biopsy is contraindicated in certain brain tumors like optic glioma, DIPG, any brainstem glioma. Otherwise, biopsy is done, followed by surgery, in which surgery, if we can remove the whole tumor, gross total resection is always preferred, followed by radiation and chemotherapy if required, depending on the type of the tumor. Again, for children less than 3 years of age, radiation cannot be given because they will have long-term side effects. At the children less than 3 years, mostly radiation is avoided. Again, depending on the type of tumor, we will give the radiation. Radiation is, if there is grade 3 or grade 4 type of tumor, craniospinal irradiation is given. Otherwise, just focal radiation is given along with some systemic chemotherapy. Now my third case is a 2-year-old child presented with swelling of the left side of the face with fungating mass for 3 months. She had history of white eye reflex in the left eye since 1 year of age. She went to nearby healthcare where they were suggested eye drops and multivitamin. On evaluation, she was diagnosed with left eye retinoblastoma with brain mets. So this is the retinoblastoma. It is a most common intraocular tumor in children. So if it is the most, initially they will present with white eye reflex. White eye reflex means if we put a torch near the light, generally red, it will be seen because of the retina. But because when a child develops retinoblastoma, a white eye reflex will be seen. This is mostly seen by mothers because mothers are the best observers. But unfortunately, in our country, till date, we will get child when white eye reflex is mostly missed, and we will get the patient when they will have fungating mass, when the tumor has spread to the brain. So it is a highly curable tumor. There are no screening tests for any of the pediatric tumors, but retinoblastoma, when a child goes for vaccination to a pediatrician, I am requesting all the pediatricians, whoever is listening, that please look for white eye reflex in the children if when they are going for vaccination. That can be caught up at that time only. And the treatment for retinoblastoma is depending on the staging of the tumor. If chemotherapy, it can be intraarterial, focal, or systemic. And if they present at advanced stage, enucleation of the tumor is done, and radiation and autologous only done in advanced or high advanced cases. So late effects of childhood, this is pertaining only to childhood cancer, because when we see all childhood cancer survivor, around 60% of them will have some chronic conditions, like they may have some metabolic conditions like hyperglycemia or chronic heart disease, or because they have received many chemotherapy, or because of respiratory infections, they may have chronic lung disease also. They may develop secondary malignancy. They may have some issue with their fertility, again because during the treatment they have lost some time while taking treatment. So it is difficult for them to go and again match with the peers. So these are the side effects, which the late effects were. So once the treatment of a child is completed, generally we send the child to their own place. So whoever pediatrician taking care of a child who has been diagnosed with cancer, late effect has to be taken care of. Vaccination has to be given, revaccination, and like probably interval echo or interval chest X-ray. And this childhood who are late childhood survivors, cancer survivors, they should also lead a healthy life. Like they should not take smoking, they should regularly do some activities like exercises and all. They should live a healthy lifestyle. With this, I end my session. And tomorrow is a 15th February, which is International Childhood Cancer Day. So inspiring action is the theme of this time. Mainly, it is to decrease the mortality due to childhood cancer, and for early diagnosis, we have to work as a multidisciplinary team. Whoever taking care of primary physicians, oncologist, surgeon, radiation oncologist, nursing care, whoever are there, we should always work together to build our future. Thank you. Squeeze.
Thank you, Tanushree, for sharing your knowledge. Now we move on to the question-based program, third session. Question number 1. So what is the most frequent site of metastasis in pediatric neuroblastoma? Choice A, so what is the most frequent site of metastasis in pediatric neuroblastoma? Choice number A, lung. Second choice, liver. Third choice, bone marrow and bone. Fourth choice, brain. Question number 2. Which of the following is not a typical presentation of retinoblastoma? First choice, leukocoria. Second choice, strabismus. Third choice, proptosis. Fourth choice, hematuria. Question number 3. The MYCN gene amplification is poor prognostic factor in which pediatric cancer? First choice, Ewing sarcoma. Second choice, neuroblastoma. Third choice, Wilms tumor. Fourth choice, retinoblastoma. I'm repeating. First choice, Ewing sarcoma. Second choice, neuroblastoma. Third choice, Wilms tumor. Fourth choice, retinoblastoma. Question number 4. A 4-year-old boy presented to OPD with abdomen distension and hematuria. On examination, there is abdominal mass. CT abdominal was suggestive of abdominal mass showing class sign. So what is the diagnosis? First choice, neuroblastoma. Second choice, nephroblastoma. Third choice, lymphoma. Fourth choice, renal cell carcinoma. Question number 5. Which chemotherapy agent is commonly associated with cardiotoxicity in pediatric oncology? First choice, cisplatin. Second choice, doxorubicin. Third choice, vincristine. Fourth choice, methotrexate. So next, our topic is quiz discussion. So first question answer. What is the most common pediatric malignancy? Leukemia and followed by solid tumors like Wilms tumor. First is leukemia and followed by solid tumors and brain tumors. Next slide.
Next slide.
Next slide. So which genetic syndrome is most commonly associated with the increased risk of leukemia in children? The answer is Down syndrome. So Turner syndrome associated with the gonadoblastoma and brain tumor. Next slide. So Turner syndrome associated with the gonadoblastoma and brain tumors. Marfan syndrome associated with the neuroblastoma. Klinefelter syndrome associated with the breast and lung cancer and non-Hodgkin's lymphoma. So the common syndrome associated with childhood leukemia is Down syndrome, Lee-Fraumeni, neurofibromatosis, and Fanconi's anemia. Third question: which of the following tumor marker is commonly elevated in hepatoblastoma? Answer is alpha fetoprotein. So alpha fetoprotein elevated in adult also in hepatocellular carcinoma. So other cancers like germ cell tumors, LDH elevated in leukemia, lymphomas, beta Sag elevated in germinoma. Next slide. So what is trilateral retinoblastoma? The answer is bilateral retinoblastoma with pineal gland involvement. Next slide. So trilateral retinoblastoma, it's a rare condition, occurs in children. It has both retinoblastoma in eye and brain tumor. So the brain tumor typically involves pineal gland. It's sometimes called third eye. So the chance of developing pineal gland tumor, it is pineal tumor plus bilateral retinoblastoma is around 4.2%. So diagnostic modality, MRI brain is best one, and plus combined eye examination also. So treatment is high dose chemotherapy and followed by transplantation. Next slide. So National Childhood Cancer Day celebrated. So answer is 15th February. Next slide. The World Cancer Day is May 28. The World Ovarian Cancer Day is 8th May. World Thalassemia Day is 8th May. The Childhood Cancer Day is 15th February. Philadelphia chromosome is associated with which childhood malignancy? The answer is ALL. So Philadelphia chromosome is it's also associated in CML in adult, ALL. Next slide. In tumor lysis syndrome, which electrolyte not seen? One is hypermagnesemia. Next slide. So in hyperphosphatemia, particularly in spontaneous tumor lysis syndrome, less hyperphosphatemia because of the phosphate is utilized by tumor cells. But in drug-induced tumor lysis syndrome, hyperphosphatemia will be there compared to spontaneous tumor lysis syndrome. Next slide. Which molecular marker is most commonly associated with poor prognosis in pediatric ALL? So it is MLL rearrangement. Next. So, next slide, please. So, most common cause of mass in anterior mediastinum in children. The answer is lymphoma. So, the lymphoma common in superior mediastinum, anterior mediastinum, and middle mediastinum. In posteriorly, neurogenic tumors are common. Next slide. So, what is the translocation seen in APML? The answer is 1517. So, 1221 seen in AML, 119 translocation seen in BALL, 922 it is CML. Next slide. What is the most frequent site of metastasis in pediatric neuroblastoma? The answer is bone marrow and bone. Next. So most common site of metastasis, lung mets is common in sarcoma and Wilms tumor. Bone and bone marrow, it is neuroblastoma. Brain liver mets, it's less common in pediatric age group. So the following is not a typical presentation of retinoblastoma. The answer is hematuria. Next slide. So presentation, so leukocoria, strabismus, secondary glaucoma, anterior segmental invasion, orbital inflammation, orbital invasion. Next slide. So MYCN gene amplification is poor prognostic factor in which pediatric cancer? It is neuroblastoma. Next slide. So 4-year-old boy presented with abdomen mass and hematuria. The CT scan suggestive of class sign. The diagnosis nephroblastoma. Next slide. So Wilms tumor, so most common in children aged 3 to 4 years. So the signs and symptoms are weight loss, and abdomen pain, swelling in the abdomen, macroscopic or gross hematuria, and systemic symptoms like fevers and malaise. Next slide. Which chemotherapy agent is commonly associated with cardiotoxicity in pediatric oncology? The answer is doxorubicin. So cisplatin will cause ototoxicity, nephrotoxicity, neurotoxicity, and electrolytes imbalance. Doxorubicin will cause cardiotoxicity. Acute toxicity will be arrhythmias. Chronic toxicity will be LV failure. Vincristine will cause peripheral neuropathy. Methotrexate high dose will cause neurotoxicity. Next slide. Thank you.
Hello and good evening, everyone. We have come to the final session of the today, which is Uta thanks. On behalf of the organizing committee, I would like to extend my sincere gratitudes to all the speakers, experts, and then participants who are all contributed to the today's sessions on pediatric oncology and hematology. Your insights into the diagnosis, early treatments, advances, and challenges has been truly enlightening. Pediatric cancers are rare diseases, but of course with very high cure rates. The cure rates is such that some of the cancers, even in stage 4 cancers, they are still curable. I would also like to thank all the attendees for your continued engagement and interest. We hope this session has inspired and motivated all of us to continue working towards the betterment of the patients who are being diagnosed with pediatric cancers. Our next session, our next webinar will be on 20th of this month, that means 20th of February. The answers for the today's quiz will be announced on 20th of February. Thank you one and all. Thank you again. Would like to see you again on 20th of February for next session on breast cancer. Thank you everyone.